American Thoracic Society published a guidelines on diagnosis of hypersensitivity pneumonitis in adults in 2020. So we are about to discuss it today. Diagnosis of HP in adults. Let's start with introduction. So HP is typically an immune-mediated disease that manifests as ILD in susceptible individuals after exposure to an identified or unidentified factor. So it is basically immune-mediated disorder. HP shares the features of other acute and chronic pulmonary diseases. As a result, fibrotic chronic HP can be misdiagnosed as IPF or another idiopathic interstitial pneumonia. So the main objective for publishing these guidelines were how to evaluate a patient with newly identified ILD to accurately recognize non-fibrotic HP and fibrotic HP in a timely manner. So they basically advise for a multidisciplinary discussions with the pulmonologist, radiologist, methodologist, pathologist, and of course patient, and they give us systemic reviews of 6 questions. Let's come to the definition. HP is an inflammatory and or fibrotic disease affecting the lung parenchyma and small airways. It typically results from an immune-mediated reaction provoked by overt or occult inhaled antigen in a susceptible individual. So it is inflammatory or fibrotic disease. It affects lung parenchyma or small airways. And we know that it is immune-mediated reaction by an antigen. Previously, it was called as extrinsic allergic alveolitis and characterized as acute, subacute, or chronic. However, these categories are not easily demarcated, so they have been removed. Because the presence of radiographic or histopathological fibrosis is the primary determinant of prognosis, now they come up with an idea of HP categorization as either fibrotic, that is mixed inflammatory plus fibrotic. So fibrotic would be inflammatory plus fibrotic, and non-fibrotic, which is purely inflammatory, given the greater clinical utility of this stratification. So it could be fibrotic and non-fibrotic. Some patients may have mixed features, so we'll classify them with what feature they are predominant with. Coming with the clinical manifestations, what are going to be the clinical features? So signs and symptoms of both fibrotic and non-fibrotic HP include dyspnea, cough, mid-inspiratory squeaks. Less frequently, there may be a constitutional symptoms such as weight loss, flu-like symptoms, chills, low-grade fever, malaise, chest tightness, and wheezing, as well as physical examination finding of rales and cyanosis. So most important clinical features are dyspnea, cough, and mid-inspiratory squeaks. Prevalence of HP is highest among older individuals. So this is a disease which usually presents in 5th and 6th decade of life. And prevalence is about 2 to 47% in one of the studies. It can also be diagnosed among younger adults and children. Patients with fibrotic HP are more likely to be in older patients because it is a chronic process and takes time. Now, natural history and prognosis. The natural history of HP range from improvement to progressive decline and death due to respiratory failure. So it may go into improvement, it may go into progressive decline, and might lead to death. And the main cause of death is respiratory failure. Patients with non-fibrotic HP who avoid ongoing exposure to the inciting agent may have favorable prognosis with possibility of stabilization or full recovery. Patients with fibrotic HP, particularly those with UIP pattern, have reduced survival. So fibrotic, reduced survival, non-fibrotic, possibility of stabilization or full recovery. There are other features according to the guidelines which are associated with poor prognosis. Cigarette smoking, lower baseline vital capacity, lack of bell lymphocytosis. So lack, if there is no lymphocytosis in bell, and persistent exposure to the inciting agent. So this is very important to identify the agent and remove it. And your inability to identifying an inciting agent. So for the purpose cigarette smoking, baseline vital capacity low, and lack of bell lymphocytosis, and persistent exposure to inciting agent is the feature which is associated with a poor prognosis. It is also very important that in around 30 to 50% of the cases, we are unable to identify what was the agent at the first place which was causing HP. Epidemiology. The prevalence of HP vary with regional disparities in climate, occupational exposure, and environmental exposures. So it depends upon the geographic location or the occupation of the patient and the climate of that condition in which the patient is living. Available estimates an incidence between 0.3 to 0.9% per 100,000 individuals, but it varies. The proportion of HP among all ILDs varies tremendously, as I previously mentioned, 2 to 47% in some studies. So what is pathogenesis behind it? HP develop in susceptible individuals are very important. So there is a genetic factor behind that. After repeated exposures to one or more inciting agents, several potential inciting agents and hundreds of sources of such agents have been reported. These inciting agents are diverse, vary by geographic region, and are usually protein antigens derived from microorganisms, maybe fungi, animals, anything, drugs. They may be also polysaccharides or low molecular weight non-protein chemicals, for example, isocyanates. It has been hypothesized that inciting agent can be the part of a mixture of, it could be like more than one microproteins or other matter dust. Sources of antigens known to cause HP. So these are the sources, these are the typical sources, and this is the disease which we are going to call. It could be microbes like fungus, yeast, edible mushrooms, bacteria, protozoa. Other categories: protein enzymes, animal proteins, inorganic particulate matters like chemicals, pharmaceutical agents, or metals. There are so many, so you can see from the table. Now coming towards non-fibrotic HP, or also known as a cellular HP. The typical HP pattern rely on identification of diffusely distributed HRCT findings that include lung infiltration, which are ground glass opacity, mosaic attenuation, plus at least one HRCT abnormality suggestive of small airway disease. So there are two things. One is lung parenchyma involvement, Their changes are going to be visible on HRCT, and one is small airways. In lung parenchyma, you can find ground glass opacity and mosaic attenuation. HRCT features of small airway disease are ill-defined small 5 mm centrilobular nodules on inspiratory images and ear trapping on expiratory images. So in lung parenchyma, you can see ground glass, mosaic attenuation, and in small airways, you can find centrilobular nodules which are ill-defined and small with ear trapping. Mosaic attenuation refers to coexisting areas of varying attenuation within the lungs parenchyma on an HRCT image. So attenuation will be varied. In non-fibrotic HP, mosaic attenuation typically reflects coexisting lobules affected by pneumonitis. So let me repeat it. Non-fibrotic HP, typical HP pattern on HRCT would be features of lung parenchyma involvement, that is ground glass and mosaic, plus small airway disease, centrilobular nodules which are ill-defined and small with ear trapping. This is a very good table in which they compare the just HRCT scan features of non-fibrotic HP pattern and divide them into typical, compatible, and indeterminate. In typical, the typical HP pattern is suggestive of diagnosis of HP. It requires at least one HRCT abnormality indicated of parenchymal infiltration and at least one HRCT abnormality indicated of a small airway disease, both in diffuse distribution, as being defined above. Then we are going to say this is typical. Diffuse distribution involving of lung parenchyma, involving of a small airway disease. So what are the patterns which shows that it is parenchymal infiltration, ground glass and mosaic attenuation? And what are the patterns which indicative of small airway disease, ill-defined nodular, centrilobular nodules and ear trapping? And distribution, diffuse. Craniocaudal with or without some basal sparing, but it would be diffuse. Compatible are pattern non-specific, maybe parenchymal abnormalities uniform in subtle ground glass, ear space consolidations, cyst. Distribution could be variant like lower lobe predominance or diffuse, but we are not going to find anything in indeterminate. Now coming towards histopathological features of non-fibrotic or cellular HP. A confident histopathological diagnosis of non-fibrotic HP requires presence of typical histopath features, which are cellular interstitial pneumonia, accentuated around small airways, bronchiolocentric with cellular chronic bronchiolitis, a distinctive pattern of granulomatous inflammation, or no histopath features suggest a more likely alternative diagnosis. Cellular interstitial pneumonia, cellular chronic bronchiolitis, granulomatous inflammation, which is poorly defined. And this is the thing which distinguished it with sarcoidosis, because in sarcoidosis it is well defined.